I always start by just defining addiction. I think it's really important for people to understand that addiction is a chronic disease. It acts like every other chronic illness. It's a relapsing, remitting disease. We see people do better at certain times. We see people do worse at other times in their life, just like they do with diabetes, just like they do with hypertension, just like they do with asthma. And so the same sort of treatment principles exist when we're thinking about the longitudinal care of somebody with a substance use disorder. We can expect people to struggle with it at different times in their life. We can expect people to be under better control at other times of their life. And that's a very normal part of the disease progression. We call these the ABCs of addiction. For those folks that kind of like those mnemonics, really what we what we need with it to define it, what we need when we're looking to diagnose addiction is something beyond tolerance and withdrawal that is sort of ego dystonic with how that person wants to lead their life. So it is it is easier to think of it, I think, that way than it is to think about like cravings and all the different like specific diagnostic criteria because if you go through and you treat the diagnostic criteria like a checklist and ask the patient, do you have cravings? Do you have right? Then you don't usually get to like an actually really well thought out diagnosis. So I usually think of it as you need something that is kind of ego dystonic with with their with their substance use. And those three buckets fall into impaired control, social impairment, and risky use. So that that those are kind of the broad buckets that I'm thinking about when I'm diagnosing someone. You can see that I did not even touch on the pharmacology piece of it. Because in order to have a substance use disorder, you need three diagnostic criteria. And at least so you have to have something outside of tolerance and withdrawal because we all know that anybody who is prescribed licit chronic opioids is going to have tolerance and is going to have withdrawal over time. So we need to have something other than that. I think that is a piece of the diagnosis that is often difficult for non-addiction specialists to really wrap their head around because they'll take some behaviors that might be very normal for somebody who's on chronic controlled substances and misinterpret those as maladaptive behaviors related to a substance use disorder. And what I'm sort of getting at and tiptoeing around is that when that person calls every time like clockwork to get their refill on their medication, and we're like, man, this patient calls every time like clockwork. I think sometimes we don't always remember that if they don't, and we don't prescribe the medication on time or the pharmacy doesn't have it, then and that person goes without medication for a period of time, even if it's just a day or two, they're going to start going into withdrawal. And withdrawal is miserable, whether it's stimulant withdrawal, whether it's opioid withdrawal. Like it's just not fun. Classically, with opioid use disorder, we learn that we learn that that withdrawal feels like the flu. I always tell people it feels like the flu. And if you're anything like me, when you have the flu, you want to like go into your bed, close the door, sleep, hope you feel better when you wake up, right? And your body just is weary and wants that rest, and you're exhausted. You might sleep fitfully, but you will sleep. When you have opioid withdrawal, you have to add not only flu-like symptoms, but the worst insomnia of your life. So the one thing that you want to do is sleep, and the one thing you can't do is sleep. So it's pretty miserable. And people will go to great lengths to avoid withdrawal. And withdrawal avoidance is not a diagnostic criteria. And I think that's one place where a lot of times people struggle as providers in this space. I mentioned that we talk about addiction like a chronic illness, and here's some data to back me up. comparison of recurrence rates between diabetes, substance use disorder, hypertension, and asthma. And I'm sure you've all already realized that those confidence intervals pretty much all overlap. They all overlap with substance use disorders. Type 1 diabetes may be a little bit better than the hypertension and asthma. So when we look at folks that have a substance use disorder and they've returned to using, and being in a society that was developed and based on puritanical principles, we have determined that people with a substance use disorder should have the willpower and should have the strength not to use. And so when they come in and they've had a recurrence, we beat them up because that is what we have learned to do. And I just cannot impress upon you enough the number of times I've had the conversation with the patient. So you return to using and you showed up here. So I'm assuming that that is not what you want to be doing. And they say yes. And I ask them, so have you beaten yourself up adequately for your use? And they invariably say yes. And I say, is there anything I could do that would make you feel worse about your use? And the answer is no. And then I will say to them, so let's start thinking about, let's not ignore what happened. Let's think about how we got to the point where we were using. And let's think about what we can do differently in the future to better support you as a healthcare system. Boom. Changes the conversation, changes the tone. You all are gifted at helping families, helping patients through making a much more difficult transition in their lives. And so that's what we do in addiction as well. We try to pivot that conversation and change that conversation to be kind of strengths-based. How are we going to support you? What can we do differently? What are your personal needs? How can we help you address those? The pleasure reward center is a beautiful place in the brain. We all only have one. It is the same in us as it is in many other animals. It is part of what we may have learned in medical school as the reptilian brain. As I like to tell people, if I put a gecko on the table, even if I could speak gecko, I couldn't rationalize with them because their brain doesn't have that capacity, right? And so what we think, so what we have to remember with the pleasure reward center is that this is a very powerful area of the brain. And I tell people all the time that I have a strong family history of substance use disorders. I am not a survivor of a substance use disorder, but I am a person whose life has been impacted by substance use disorders very intimately. However, I kind of know that my brain lights up differently than my husband's brain, who doesn't have I remember when we were, dating, and I said, doesn't someone in your family have a substance use disorder? It was mind-boggling to me that he was like, no. And I was like, really? There's families like that don't have this disease. His brain just doesn't light up the way mine does. We lead I lead an abstinence-based lifestyle, so I don't, I drink Diet Coke. I do caffeine. I drink 1 12-ounce Diet Coke every day. That's my drug of choice. But we don't have alcohol. We don't have cannabis. We don't have cannabis products. We don't have any of that in our home. And, I can count on, one hand the number of times my husband's had a beer in the last year because he could take it or leave it. The last time he did was we were at a restaurant. It was just the two of us. He refuses to consume alcohol in front of our children. And he when I was in med school, he did this weird thing called travel the world. And I guess there was some beer on the menu that reminded him of one of his travels. And he was like, oh, I think I'll have that. I was like, okay, sure. Right. But he had one beer and he has an off switch. I don't have that off switch. And that's based on kind of the pleasure reward center, right? And it sends these very powerful messages through dopamine, which is our drive chemical. And it says that felt good, we should do it again. It sends these very powerful messages to the front of the brain. And then we have to use kind of the frontal cortex and the thinking parts of our brain to stop that message. Now, the average age of first use of a substance is between 11 and 13 years old. I don't know about you guys, but I think I was closer to playing with baby dolls than I was to being a doctor at that point. And so I can't blame, if I can't, I refuse to hold myself responsible for decisions I made when I was that age. I can tell you in my own life, when my patients tell me that, it's not uncommon for me to hear that it was a parent, a cousin, somebody who's supposed to protect you as a child who was the first person to give them, to give them a substance. I can tell you in my very life, I remember sitting on the counter at age 12 years old. I know what house I was in because we moved around a lot as kids. We moved back to house number 10. So it was like my 12th house. But when I was a senior in high school. So I know how old I was based on which house we were in. And so I was 12 years old. And I was sitting on the counter. I'd had a bad day at school. I don't even remember what happened. And my mother told me she knew exactly what would make me feel better and handed me a shot of vodka. So if that happened in my own life, that can happen in my patients' lives. And I cannot judge. And I'm lucky and thankful that I didn't end up going down the route of developing an alcohol use disorder when that was the exposure that I received as a child. My younger brother was not so fortunate. My younger brother started drinking around age 14 and died 10 years later of a self-inflicted gunshot wound related to his alcohol use disorder and his severe persistent depression. We don't know what happened to somebody when they were a child. We talk about addiction as being a disease of development. The vast majority of my patients started using as adolescents in their early 20s, and our frontal cortex is not fully developed until we're in our late 20s. And yes, ladies, the male brain develops slower than ours does. So they're more like late 20s and we're like mid 20s, just in case people were wondering. So what happens when somebody uses a substance is that their pleasure reward center just lights up significantly, and it results in a huge release of endorphins. And what are endorphins? Why, endorphins are endogenous opioids. So what gives us pleasure in life? Opioids. So you can see that release from cannabis, from heroin, from methamphetamine is way higher than kind of best day ever. Oh, look, there's updates available. I don't know if that popped up for you guys. We will officially ignore updates from my computer like any good person does. So best day ever does not release as much endorphin, does not drive us forward to use, does not drive us forward to recreate that day nearly as much as cannabis or opioids. And look at methamphetamine. When somebody comes in with methamphetamine use, there's nothing I can say other than like, life is never going to be as beautiful as it was the first time you used methamphetamine. Nothing in life can give you the same feeling as you got that first time you used meth. That's what makes it so hard to stop using. We're going to play a little game. It's a carrot. Doesn't that look yummy? Who wants to have like a bowl of carrots right now because you're just craving carrots? Anyone noticing any physical changes in their body when they see the carrot? Increased salivation, craving, a yearning for carrots. No, no. I know this picture is coming, and every single time it pops up, I still salivate. Why does the ice cream sundae do something different than the carrot? I mean, it's like 2 degrees outside, right? Like, why am I even caring? Like, I know it's a picture. There's not even ice cream in my house, much to my children's chagrin. My daughter was just complaining about that last night, as a matter of fact. But still, my body is like unconsciously responding to the image of an ice cream sundae. This happens to people like your brain and your body are preparing to digest the ice cream sundae, even though it's a picture, and even though we all are like consciously aware, our frontal lobe is aware that that is a picture. Nobody is trying to like grab at the ice cream sundae thinking it's real. But the unconscious areas of our brain are saying, you better get ready to digest that picture because evolutionarily they can't tell the difference between a picture and a real one. What is that area of the brain? It is the pleasure reward center because the pleasure reward center is also responsible for our drive for sleep and our drive to consume food. So you don't have control over yours. My patients don't have control over theirs. It's the same area of the brain. So I hope that makes you kind of understand how this works. Now, that is also what can be really hard if somebody is exposed to a substance and kind of that whole concept of just say no, be strong enough. If I walked in with a tray of ice cream sundaes, there would be people who were not interested in eating an ice cream sundae prior to that event that maybe still weren't that interested in eating the ice cream sundae, but would eat the ice cream sundae because they will get pleasure and reward from that. There also may be people in the room that are lactose intolerant, and those folks are going to have a few different responses. There's going to be the person that says the pain is worth the gain. The pleasure is worth the pain. I'm going to eat it and know that I'm going to be bloated and feel icky afterward. But I don't care because I want the pleasure of the ice cream sundae. It's going to taste good going down. There's the next group of people that are looking in their bags, rifling through their pockets, going, do I have Lactaid? The pain is only worth the gain if I can prevent the pain. Otherwise, I will not eat the ice cream sundae. And then there are the people that are that are like feeling a little queasy from the picture of the ice cream sundae, never mind the imaginary real ice cream sundae. That are like, I will not touch the ice cream sundae because it is going to make me miserable. And I don't care. You can give me all the Lactaid in the world and I still won't eat it. The same thing happens with opioids. I'm sure you've encountered this, right? There's the people that have, nausea, vomiting, adverse reactions from opioids, and they don't want them. And then there's the people that they feel very good for. And those are different. Those are just different brains responding in different ways, in the same way that people respond differently to lactose. So we kind of have an effective response that unconsciously results in our responding to the different stimuli. And this is also why if you talk to somebody with an alcohol use disorder or with an opioid use disorder, people will tell you that like their shakes start to go away when they're pouring the alcohol. The tremors that they get with they start to feel some relief from their withdrawal from opioids or from methamphetamine when they start the process of cooking. The rituals kind of can have an impact and diminish the symptoms of withdrawal as the body is anticipating the drug coming in and the use happening. Now, it doesn't get rid of withdrawal. It can minimize some of the symptoms for a short period of time. It doesn't it's not a treatment for withdrawal, is what I'm saying. We can actually see pretty concrete brain changes that pop up when somebody, this is an old famous NIDA study, a functional MRI, frontal lobe is in the white box, and you can kind of see that the person with cocaine use, their brain is just not lighting up as well. After a period of about 2 years of abstinence, these brains are not statistically significantly different in terms of their functional status. So when somebody has an active substance use disorder or is in early recovery, their brain is just not even able to process as well. So doing some of those things that maybe some of the healthier habits we're encouraging them to have are just that much harder in that period of time because their brain is literally not functioning as well as it once did. So I think that's just a tidbit to be aware of. That kind of that brain capacity is decreased, and so having a little bit of understanding that you might need to go through things slower or in a different way than you would if they didn't have that. if they weren't actively using or weren't early in recovery. So I often get asked, why do some people become addicted to drugs and not other people? There's a confluence of factors that can lead to it. I talked a little bit about the biological factors. There are developmental factors. We know that some of the epigenetics of addiction can impact lifetime risk of substance use based on exposures prenatally. We also know that there are a ton of environmental cues and challenges. We know that people who have 4 or more ACEs have a 12 times increased risk of a lifetime substance use disorder, which is one of the highest risk factors in the ACE studies. So it's kind of one of the disease that is most impacted by those adverse childhood experiences, despite there being increased risk in cardiovascular disease, lung disease, COPD, asthma, with adverse childhood experiences. So we know that those experiences can kind of live with us for life and change our gene expression as well. I do have to point out that that if your brain is never exposed to heroin, you're not going to develop a heroin use disorder. So that that certainly plays a role in terms of what is available to you and what is around in your community, in your home, in your peers' homes. I'm gonna skip that one. Addiction, I like to tell people, it kind of hijacks the brain so that that frontal lobe is kind of unable to put that stop. So that person that is, to go back to the lactose intolerant, they are not going to be able to even process the pain is worth the gain. They are going to use. There's a real really commonly used and cited YouTube video called Nuggets. If you Google search Nuggets and addiction, it'll pop up. It's like a little bird-like thing, and it goes and it starts exploring substance use and then develops a substance use disorder. And so that ability to kind of put the brakes on, to stop, to send the message back. And we just saw slides showing that the ability of the brain to process in the frontal cortex is also minimized during active addiction. So they're at, like, it's a double whammy. They're at a significant disadvantage for being able to engage in and change their behavior. So having a little bit of understanding and kindness, and that's where some of the medications to treat a substance use disorder can be very helpful, because those medications can kind of stabilize the brain in order to allow that person to have some healing time and to not have as much of, it doesn't completely ameliorate, but as much of the cravings and difficulties. And that's really what almost all of our treatments for addiction do, is kind of stabilize that pleasure reward center so that the person's brain is stabilized, so the drive to get substances ends up being minimized. We now live in a world of fentanyl. In West Michigan, about 97% of our heroin supply is actually fentanyl. So we don't actually have heroin anymore. When we look at some of the newer additives that are in our supply, like xylazine, one of the reasons that we think our overdose rate has gone down is that xylazine is actually a tranquilizer and not an opioid. It's mixed in with the fentanyl. It has a longer half-life, so people nod off and fall asleep before they take another dose, and that reduces their risk of withdrawal. Whereas with more fentanyl pure products, people use more frequently and end up dose stacking and overdosing that way. Xylazine is the one that causes the big black eschars, and it can be at sites distant from where somebody injects. So it's not like better, it's just different. But we did over the last year see a over 6% reduction in overdoses in Michigan, and another large part of that is naloxone distribution. So anyone in Michigan can go onto the naloxone portal at the state of Michigan and actually order naloxone. I remember like 10 years ago when my kids were little, my husband at the time was a stay-at-home parent, and he used to always joke around that, he's got diapers, wipes, snacks, and Narcan. He's like in the diaper in like the bag that he carried around for the kids, right? And he was always like, I don't know why you make me carry this around. And I was like, because if somebody overdoses and dies on your watch, I'm never going to forgive myself if you had the ability to carry Narcan and you didn't. So if any of you are not carrying Narcan today, I am happy to drop off a box of naloxone or facilitate ordering a pack of 12 or more if you need more for your site. But we have actually very strong Good Samaritan laws that protect us as Good Samaritan citizens, but also protect us as physicians if we do or don't use naloxone, when it would be indicated. If somebody is not breathing, one of the first things EMS does is give Narcan, check blood sugar. Like that's what they do. And they have done that for decades, since the 70s. So it's a very well-established protocol. You are not going to harm somebody giving them naloxone, even if it's not the result of an overdose. So, if somebody's not breathing, naloxone, 911, chest compressions. Happy to come back and do a naloxone training if that's of interest. Or when I come back, we can maybe talk about that, Dr. Mulder, if that's of interest. So again, we did see a slight dip this last year, but we definitely are trending along the lines of the national average. There were some more increases in the coasts over this last year, so our decrease was greater than many of the other ones. So we know that the vast majority of overdose deaths involve synthetic opioids, which is fentanyl, and that correlates with kind of what the national data is showing. If you go to Baltimore, you can still actually get heroin, so you can actually ask your drug dealer for fentanyl or heroin. So there are some small enclaves where you can still access heroin alone, but none that I know of in Michigan work that way. We can also see that there are some disparities in terms of who is dying in Michigan. This one has been increasing over the last year as well, so that and there are targeted interventions that are being discussed at the Department of Health and Human Services to address some of these disparities. We are seeing the largest decrease, like much of the nation, in the white population. We see more access to care. People who are white are more likely to be offered medication to treat their substance use disorder than people of other ethnicities. I think I talked a lot about stigma and what that looks like in kind of the story that I started with. But it is a huge part of what I work with and what I battle every day. There are different layers of stigma. We have there is self-stigma, the stigma that my patients have with themselves, kind of going back to the have you beaten yourself up about this already? Okay, great. Thanks for coming back. We won't be beating you up anymore. We don't need to take on that role. There is stigma that comes, as we talked about with the story, from the healthcare system about whether or not this person is of value to be treated and what resources we're willing to utilize to treat that person. There is stigma that comes from society. There's stigma that comes from family and friends. So there are so many layers of stigma that I strive. I'm not perfect. I strive to create an environment in my clinic where people feel welcomed, where I am hopefully providing them with kind, compassionate, person-centered care, so that they feel valued and respected when they walk through that door. So these are kind of, I just went through these. So these are kind of the different types of stigma I just reviewed. So it is really important to note that healthcare professionals are the most commonly cited source of stigma for patients receiving treatment for substance use disorders. So Stigma is real, it's pervasive. And when somebody walks into the addiction clinic, my introduction is, hi, I'm Dr. Poland. I'm the addiction doctor that will be taking care of you. Thank you so much for coming in to see me today. I'm really excited to get to know you more. Whoa, sort of changes the tone of the conversation. Because what they're expecting me to do is be a source of stigma, not be a source of kindness and compassion. And they're often very scared, and it takes a tremendous amount of strength and bravery to walk into an addiction clinic. No other physical or mental illness is stigmatized more than substance use. Number four is alcohol use. So there's a couple of these states that beat alcohol for stigma, but nothing beats, illicit substance use. So that's fun. And, worldwide, right? Worldwide. This is not unique to the United States. And so when we treat people and there is stigma involved in that care, we have less empathy for our patients. We are less involved with our patients. That story showed how many people in the system had lower empathy, didn't take the time to provide the patient with safe, appropriate, adequate transitions of care, maybe didn't spend enough time with the patient, got frustrated with the patient. That resulted in him feeling like he couldn't be engaged and wasn't safe with those providers. And then they leave. And that is something that that's in our power to change. That is something that we can do differently. So I know I'm bouncing against the time, but this slide is just to say, if we did some of the things that we do with people with substance use disorders in the healthcare system on a day-to-day basis, it would be considered malpractice. People with an alcohol use disorder who are discharged with an FDA-approved medication to treat their alcohol use disorder have a 51% decreased 30-day readmission rate. Yet the number of times that I go do trainings with residents, that I talk to hospital-based physicians, and I ask them if they even offer medications on discharge after an alcohol withdrawal episode, and the answer is no, is atrocious. Less than 4% of people who should receive medication to treat an alcohol use disorder actually receive medication to treat an alcohol use disorder. 4%. Imagine if that was diabetes. To make you feel a little bit better about the 4% statistic, we only provide about 40% of the appropriate care that somebody should receive with diabetes. So it's an order of magnitude, but it's not like it's 90%. But really, it's quite disheartening, and these medications are pretty easy to prescribe. There's 3 FDA-approved medications to treat alcohol use disorder. One of them is not effective, so we don't really use it unless the patient's really driving it. So really only need to learn about 2 medications. It's not that hard. It's not technically difficult. I tell people all the time, a monkey could do my job. I just get to do it because nobody else wants to do it, and I get to have more fun every day than everyone else because I have the best job ever. There are a tremendous amount of legal and systemic challenges that face somebody with a substance use disorder. You can see the number of people in prisons for drug offenses has grown astronomically since the war on drugs was proclaimed. And the war on drugs really was something that was targeted against low income, the hippies, and minoritized populations. And like they've even like people who orchestrated it have gone so far as to admit that. And that incarceration has just a lasting impact on people's lives, right? They're not eligible for federal student loans. Employment background checks can limit their employability, and they're not able to qualify for federal housing assistance, and many rental agencies require background checks, and so they're also limited on the commercial side from getting housing as well. So there are, if you notice any white areas, there is not at least one person who prescribes buprenorphine in that county. So you can see that there are wide swaths of Middle America, as well as our Upper Peninsula and Upper Lower Peninsula, that really have next to no access to addicted to opioid use disorder treatment, and we use that as a proxy for addiction treatment. There is now one methadone clinic in Michigan's Upper Peninsula, and it is located in St. Ignace. So it is kind of right there where the cursor is, if you can see right across the bridge. So wide areas of Michigan are not within a 30-minute one-way drive of a methadone clinic, which is the marker that the federal government uses to note accessibility of methadone. And there's like one here, there's one here, and the rest of Michigan's upper lower peninsulas also has no access. So how do we challenge the stigma? Be kind. Speak out against it when you see it, help train other healthcare professionals, try to be kind and empathetic, be mindful of our language. The diagnosis of substance abuse hasn't existed in over a decade. If you see it in a chart, just do the little delta sign, change it to substance use disorder. We know that when we just do that, when we just change the language that we're using and don't use the word abuse, we actually provide higher quality, more evidence-based care to patients. We also know that from a community standpoint, when we use the word substance use disorder versus substance abuse, the public is more likely to think somebody with a substance use disorder is deserving of treatment and will benefit from treatment. That's really what I'm talking about here. These are some more words. People are not addicts. A person may live with addiction, right? We've been talking about person first language, I think, in the substance use space a little bit longer than some of the other areas of medicine, but really that person first language is really is really powerful for treating people. These are just some of the words that we may want to think about changing. I also want to remind us all that it's not just us. We're not bad people, because the healthcare system is a huge part of the stigma. But it's also driven by the guilt and shame that we feel because we don't have the tools in our tool chest to treat these patients. And this was a study that was done with nursing colleagues, and so but I think this translates to all of us as healthcare providers. People have a right to help in treatment, caring conversations, and relationship building, appropriate and safe treatment, and a feeling of mutual trust and non-judgment when they walk into the healthcare system, whether it's an outpatient, inpatient, or other care setting. I end all of my talks to all the people who have lost their lives to addiction and those that try to prevent further losses. As I shared with you, my life has been intimately touched by the disease of addiction. And I want to thank you all for inviting me back again, for taking the time to spend the part of your morning with me. And I'm available should you have any further questions. And I believe I come back. I don't remember. I know I come back. I don't remember exactly when.
I don't remember the exact date either, but thanks again, Cara. This is always just so insightful, meaningful, and even though I've heard this many times before, it was perfect because our fellows, they're just a one-year fellowship. They've not heard it before, and they need to. And those of us that have heard it before need to hear it again. I don't think that we can hear this message because you're right. The approach to patient care is irrespective of the chronic disease that they come to see us with. And so the mindfulness of our implicit bias, the fact that words matter. I just had my note in the text column was that this concept of unconditional positive regard for everyone is just an essential component. And so you've reminded us of that. We, within our specialty, because we tend to hold the reins on a lot of opioid prescribing, I think need to be more sensitive to this. And I know you touch upon that in the second lecture, but thank you for this. This was great. And so we'll look forward to the next time.
Thank you for having me.